doing, it's a European product, which is an extract from the ox tail. So it does work quite well, and several clinical trials prove that, the biomechanics of the joint can get better. And finally, when you have an inflamed joint and joint affected by osteoarthritis, part of the problem is that the blood vessels grow inside of the joint in kind of chaotic way, and that process can also trigger inflammation. The scientific name for that process is neoangiogenesis. And basically in Japan, many, many years ago, they came up with a sea cucumber extract to inhibit that process, and apparently it's been shown to work for patients with knee pain and osteoarthritis. So the next step, we'll talk about platelet-rich plasma therapy, which is relatively new therapy. It's been designed within the last 8 to 10 years. And so the whole premise of the therapy is based on the fact that platelets, when they attach to solid surfaces, they release growth hormones and growth factors. And these growth factors, they attract stem cells, and they create a scar-like tissue. And the scar-like tissue can cover the defects in the cartilage. So that's the whole idea behind the PRP therapy. So the PRP therapy now is used to cover defects in tendons, ligaments, much more frequently than in cartilage. But over the last 2 or 3 years, you can see a number of publications showing that that PRP therapy works for patients with osteoarthritis. And last year, it was endorsed by the premier place in the United States, which is Hospital for Special Surgery in New York. So they endorsed PRP therapy to treat osteoarthritis of the hips and knees. So again,
how long does it last?
So it's a very good question. It depends on how damaged the joint is, and it depends on the age of the patients. Younger patients benefit much, much more from that. Older patients benefit less. And it depends how large the defect in the cartilage. It works extremely well for tendon and ligament injuries, so we use it in our practice very frequently for example, rotator cuff syndrome. So when you have shoulder problem, independent from your age, it works beautifully well. So if you have a large defect in the cartilage in the knee, it may not work so well. Yes?
Most insurances won't cover protein-rich plasma injections, so what's the cost?
It varies, it depends. So basically, it depends on a number of things. So it depends what kind of technique is used. So the price range between $400 up to $800 per injection. So, but it depends. So right now there are different machines to separate platelets. So if, for example, using a laser sorter, so the procedure will be more expensive, but you get better product because you get much, much purer platelet-rich plasma. If you use syringes with gel, so the procedure probably will be on the low end, but then the platelets will be contaminated with white cells, and you'll end up with a kind of pretty severe inflammatory reaction after injection.
So the patients are coming in, you're drawing the blood, spinning it down, and then injecting it in
Yes,
on the same day?
yes, not within the same day, within 10 minutes. So.
Okay. And then if it were a CMC joint, after they've already had their injection with hyaluronic acid,
right.
How many times do they go for those injections?
Okay, very good question. So in general, the PRP is designed to basically be injected 3 times on a monthly basis, once a month times 3. So that's a standard protocol, and obviously there are deviations from the protocol. So CMC injection is very easy because it's a very superficial joint, it's very accessible, and again, it requires a very small amount of platelet-rich plasma.
Does Medicare cover this PRP?
The Medicare covers the procedure portion. Medicare doesn't cover the platelet separation portion. So basically, let's say if the price is around $500 or $600, so Medicare covers half of that. So. And then we'll talk about physical therapy because that's something which definitely needs to be introduced as a part of treatment protocol. So quite a few patients in our practice, they're dealing with bone spurs. So what are the bone spurs? These are kind of bony growth on the bones which can damage tendons and ligaments and create major source of pain, right? So how do you deal with bone spurs? So if you shave them during the surgery, they grow back. So it's not an option. So we came up with iontophoresis with acetic acid because bone spurs are part of the bone, and bone consists of calcium. So if you can dissolve calcium, you can eliminate the bone spurs. So, and the procedure called iontophoresis. So, what does it take? So, we put electrodes on the areas where we have the major growth of the bone spurs, and one electrode is filled with acetic acid. Then we create a special electric currency which forced acetic acid into the damaged area, and it slowly dissolves bone spurs or calcium crystals. So, and then we use ultrasound to soften those areas and laser to kind of, solidify them. And so we have great success rate with our approach. So Classful Laser was invented around 10 years ago, mainly to reduce inflammation, and it's a very valuable addition to physical therapy, manual therapy, and Pilates. These are all parts of physical therapy which we introduce in our practice, and I'll show a couple of slides. So this is an example of iontophoresis. For example, this is a neutral electrode, and this is electrode filled with the drug. So we plug it in, it takes around 10 minutes, the drug penetrates in the affected joint, and then after that, our physical therapist is using ultrasound to kind of soften the bone, and then after that we use laser. And so we have very good success rate. So we use it for patients with various bone spurs in shoulders, knees, elbows. We use it for people with calcium deposit in the shoulders and knees. And success rate around 80-85%. So Classful Lasers, again, these are the modalities which were introduced around 10 years ago. So how does it work? So first of all, laser provides very deep heating. It's an infrared laser. So it increases circulation, it stimulates oxygenation of the tissues, and also it increases venous and lymphatic return. So typically it takes around between 8 to 10 treatments to notice a difference. And so far we've been using it for over 5 years, and we're very happy with the outcome. So this is our therapist, Julie, who is using a hot laser for the hand therapy. So you need to move laser all the time because it's very hot. You cannot put it in one spot at cold. So, so again, laser therapy is very efficient in our practice. Manual therapy is part of, again, physical therapy. The goals of manual therapy is to reduce pain, to increase joint range of motion, increase joint proprioception and stability, and also to increase muscle strength. Finally, we introduced Pilates because people think Pilates is part of kind of gym, but I think Pilates should be used as part of physical therapy. So it's a very gentle kind of sort of exercises, and again, probably you know that Pilates embodies complete coordination of body, mind, and spirit. And we start using for patients with balance problems, patient with low back pain, patient with scoliosis, posture, and we have pretty good success rate with that as well. And so this is just an example of how it works. So I'll be more than happy to answer any questions, and so we can do a kind of open Q&A if you want. Yes?
Is the fluoroscope guided knee injection the same as ultrasound?
Yes and no. First of all, you get radiation, right, during fluoroscopy. Number two, you don't see soft tissues. You see only bones. So you don't see fluid. You don't see nerves. You don't see tendons and ligaments. So it's much more expensive. So again, it's not exactly the same. Questions?
One more.
Yes.
When are we going to have a cure for arthritis?
It's a good one, right? So I think.
Is there anything on the horizon at all that offers
Yes, I would say probably with the next 10 years we'll see something dramatic. So mainly we're talking about 3D cartilage printing, right? So basically the first study which was published actually from Scripps Clinic this year, so showed that you can do it in animals already. So you can grow cartilage and then print it in 3D, right? And so you can attach it to the defected bone and joint, and so it works well. So in rabbits you can do it already, right? So it takes around 10 years, but I think that's the next step. So it'll be the new kind of bone and joint replacement therapy, but it'll be based on your own cartilage, right? And so it'll be not the titanium or ceramic, it'll be your own cartilage, your own bone. So I think that's the future. I would guess 10 years from now we'll be there.
Have you heard of any successes with some of these people going offshore to have stem cell?
Well, stem cells are available in San Diego, so you don't need to go offshore. It doesn't work well.
Okay.
It works for specific conditions, but not for osteoarthritis. So I was thinking about bringing stem cells to our clinic a while ago. So I was talking to main people like in LA and from Arizona. And so they told me that success rate with stem cells are equal to PRP, but it's much more invasive and much more pricey. So it's not worth it right now. Yes. Whoever is the first.
Is this patient mainly having trouble with knee pain? Is that, do you know?
It's just an example. So basically, knee pain and spine.
Spine also.
Yeah. Yes.
I was just wondering why don't more people use ultrasound guided in the diagnostics?
You know, it's a very good question. So I was one of the first actually in California who started using it around 10 years ago. At that time, I was working at Scripps Clinic. And I'm still probably the only one in San Diego who is using it. And I don't understand why. So if you look at Europe, for example, 80% of rheumatologists in most of the European countries using ultrasound just routinely. You know, I don't understand. So American College of Rheumatology last year started pushing it to use it because, I mean, it's a no-brainer. With your hands, you miss half of the times, you know, what you're supposed to see and feel. Even if, let's say, you have a patient with fluid in the joint, right? With the hands, you don't feel it. You put a probe. I mean, it's a no-brainer. Why? I can't tell you. You know, and sometimes it's a matter of curiosity because, like, there was a meeting a couple months ago, a friend of mine who used to work at Scripps Clinic, and he works at Georgetown University right now. So he was giving a talk about knee injections under ultrasound for rheumatologists. And one of the rheumatologists from Sharp stood up and said, you know what, our administration prohibits us to use ultrasound. And I said, I don't understand why. It's kind of a no-brainer. It's much, much cheaper than any other imaging. It's like 10 times cheaper than MRI. It's 3 or 4 times cheaper than the X-rays. It's completely non-invasive, no risk for patients. I